So good morning everyone, and the topic of today's lecture is antihypertensive agents. And arterial hypertension is the most common disease in the world, and about the one-third of the people in the planet have arterial hypertension, and it can be uh, higher prevalence in old people and depends on the education, race, and many other things. Uh, and uh, hypertension is developed more frequently in men than in women, and the elevated blood pressure, if not treated, can damage the kidney, heart, brain, and lead to the increased renal failure, coronary disease, heart failure, stroke, and dementia. So the latter are usually seen in old people. Uh, the uh, Currently there are many effective drugs for the lowering of blood pressure, and that reduces damage to blood vessels, and also reduces morbidity and mortality. But uh, most of the hypertensive patients usually don't take medicines regularly, and that leads to the uh, development of these diseases. Uh, so to diagnose the arterial hypertension, the measurement of the elevated blood pressure should be done, and according to this classification by Joint National Committee on Prevention, Detection, Evaluation and Treatment of High Blood Pressure, the arterial hypertension is classified to pre-hypertension, that is, uh, Allah, you asked, I think you asked me, not you, no. So the pre-hypertension is the uh, systolic pressure of 120 to 135, and diastolic from 80 to 89. Then the hypertension is everything that is higher than 140 for the systolic and 90 for diastolic. Then stage 1 is 140 to 159 and 90 to 99. And stage 2 is everything that is higher than 160 for systolic and 100 for diastolic. So with every step, the systolic pressure increases by 20, from 120 to 140, and from 140 to 160, and diastolic pressure increases by 10, so from 80 to 90, and from 90 to 100. And the research shows that the risk of damage to the kidney, heart, brain, uh, and uh, depends on the extent of the blood pressure elevation, and even the mild hypertemia increases the risk of the end organ damage. Starting at 115 for systolic and 75 millimeters for diastolic, cardiovascular risk doubles with each increment of 20 for the systolic and 10 for the diastolic. And both systolic hypertension and diastolic hypertension are associated with end organ damage, and uh, so the risk for initiating uh, therapy increase the proportion to the magnitude of the blood pressure elevation. And the risk of the end organ damage is higher in African Americans and relatively less in the premenopausal women than in men. So that is why men are suffering more than the women. And other factors for the risk include smoking, metabolic syndrome, including obesity, dyslipidemia, and diabetes. The manifestation of end organ damage at the time of diagnosis and family history of cardiovascular disease. The diagnosis of hypertension depends on measurements of blood pressure and not on symptoms reported by the patients, because the hypertension is asymptomatic until the end organ damage is occurred already. So most of the time, the reasons for hypertension are unknown. And that is why the patients are said to have essential or primary hypertension. So the patients with a specific etiology are said to have secondary hypertension, and it is important to consider specific causes in each case. However, because some of them are amenable to definitive surgical treatment, like renal artery constriction uh, and also pheochromocytoma that we studied recently, and also Cushing's disease and primary aldosteronism. In most cases, elevated blood pressure is associated with the overall increase in resistance to flow of blood through the arterioles, whereas cardiac output is usually normal. The investigation of autonomic nervous system function, baroreceptor reflexes, the renin-angiotensin-aldosterone system, and the kidney has failed to identify a single abnormality as the cause of increased peripheral vascular resistance is in essential hypertension. It appears therefore that elevated blood pressure is usually caused by a combination of several abnormalities, and epidemiologic evidence points to genetic factors of psychological stress and environmental and dietary factors like increased salt and decreased potassium or calcium intake as contributing to the development of hypertension. Increase in blood pressure with aging does not occur in populations with low daily sodium intake. Patients with liable hypertension appear more likely than normal controls to have blood pressure elevations after salt loading. And the heritability of essential hypertension is estimated to be about 30%. Mutations in several genes have been linked to various rare causes of hypertension. Functional variation of the genes for angiotensinogen and angiotensin-converting enzyme, the beta-2 adrenal receptor, and alpha-endothelin appear to contribute to some cases of essential hypertension. According to the hydraulic equation, arterial blood pressure is directly proportional to the product of the blood flow, that is cardiac output, and to the resistance to passage of blood through precapillary arterioles, that is peripheral blood resistance. Physiologically, in both normal and hypertensive individuals, blood pressure is maintained by moment-to-moment regulation of cardiac output and peripheral vascular resistance, exerted at three anatomical sites: arterioles. So, first is resistance of arterioles, postcapillary venous is the second side of the resistance, and the heart is the third side of resistance. A fourth anatomic control site on the kidney contributes to the maintenance of blood pressure by regulating the volume of intravascular fluid. Baroreflexes mediated by the autonomic nerves act in combination with humoral mechanisms, including the renin-angiotensin-aldosterone system, to coordinate function at these four control sites and to maintain normal blood pressure. Finally, local release of vasoactive substances from vascular endothelium may also be involved in the regulation of vascular pressure. For example, endothelin-1 constricts and nitric oxide dilates blood vessels. Blood pressure in a hypertensive patient is controlled by the same mechanisms that are operative in normal hypertensive patients, and regulation of blood pressure in hypertensive patients differs from healthy patients in that the baroreceptor and the renal blood flow control system appear to be set at a higher level of blood pressure. All antihypertensive drugs act by interfering with those normal mechanisms, which we will review now. So the first is the baroreflex, and baroreflexes are responsible for rapid moment-to-moment adjustment of the uh, blood pressure. For example, the initiating transition from the reclining to an upright posture. Central sympathetic neurons arising from the vasomotor area uh, are tonically active, and so the carotid baroreceptors are stimulated by the stretch of the vessel's walls brought about by the intestinal pressure. Also, this is a baroreceptor carotid sinus, and baroreceptor activation inhibits central sympathetic discharge. So this is inhibitory neurons. And this reduction in stretch results in a reduction in baroreceptor activity. Thus, in the case of transition to upright posture, baroreceptors sense the reduction in arterial pressure that results from pooling of blood in the veins below the level of the heart as reduced wall stretch, and sympathetic discharge is inhibited. The reflex increase in sympathetic outflow acts through nerve endings to increase peripheral vascular resistance and cardiac output, thereby restoring normal blood pressure. The same baroreflex acts in response to any event that lowers arterial pressure, including a primary reduction in peripheral vascular resistance or reduction in intravascular volume. The vasomotor center activates here, and autonomic ganglia actually sends impulses to the sympathetic nerve ending that act on alpha or beta receptors. So the second control is controlled by the uh, kidney. So by controlling blood volume, the kidney is primarily responsible for long-term blood pressure control, and reduction in renal perfusion pressure causes intrarenal redistribution of blood flow and increased reabsorption of salt and water. In addition, decreased pressure in renal arterioles as well as sympathetic neural activity stimulate protein production of renin, which increases production of angiotensin II. Angiotensin II causes direct constriction of resistance vessels and stimulation of aldosterone synthesis in the adrenal cortex, which increases renal sodium absorption and intravascular blood volume. Vasopressin released from the steroid pituitary gland also plays a role in maintenance of blood pressure through its activity to regulate blood reabsorption by the kidney. All antihypertensive agents act at one or more of the four anatomic control sites. So the uh, classification, so one of the, so it can act on the arterioles, or capacitance, venous, heart, or the kidney. So these systems are connected with each other. So and also they can be regulated by the rocks. So the classification of uh, agents depends on the regulatory site or mechanism on which they act. And these categories can include the diuretics. Diuretics lower blood pressure by depleting the body of sodium and reducing blood volume, and by some other mechanisms. So diuretics act on the kidney and so mostly on the kidney. And sympathoplegic agents lower blood pressure by reducing peripheral vascular resistance, and also inhibiting cardiac function, so reducing vascular resistance, increasing cardio function, and increasing venous pooling in capacitor vessels. So these agents are subdivided according to the sites of action in the sympathetic reflex arch. The third is direct vasodilators, and direct vasodilators reduce pressure by relaxing vascular smooth muscle, thus dilating resistance vessels and increasing capacitance as well. Then the next one is the agents that block conduction or action of angiotensin, and they reduce peripheral vascular resistance and blood volume. So here it's angiotensin converting enzyme and also angiotensin receptors blockers. So these are the most effective ones. Like captopril and enalapril, also losartan and other sartans like valsartan, candesartan. So the drugs that act with different mechanisms permits the combination of drugs from two or more groups with increased efficacy and sometimes decreased toxicity. So we start with with the diuretics and drugs that alter sodium and water balance on diuretics. Uh, the dietary sodium restriction has been known for many years to decrease blood pressure in hypertensive patients. Probably you heard that from your uncles and grandparents. And with the invention of diuretics, sodium restriction was thought to be less important. However, there is now general agreement that dietary control of blood pressure is a relatively non-toxic therapeutic measure and may even be helpful. Even modest dietary sodium restriction lowers blood pressure in many hypertensive patients. So the diuretics lower blood pressure primarily by depleting the body sodium stores. Initially, diuretics reduce blood pressure by reducing blood volume and cardiac output. Peripheral resistance may increase. After 6 to 8 weeks, cardiac output returns toward normal while peripheral resistance declines. Sodium is believed to contribute to vascular resistance by increasing vessel stiffness and neural reactivity, possibly related to altered sodium-calcium exchange with a resultant increase in intracellular calcium. These effects are reversed by diuretics to sodium restriction. Diuretics are effective in lowering blood pressure by 10–15 millimeters of mercurium in most patients. And diuretics alone often provide adequate treatment for mild or moderate essential hypertension. In most severe hypertension, diuretics are used in combination with sympathoplegic and vasodilator drugs to control the tendency towards sodium retention caused by these agents. Vascular responsiveness it has the ability to either constrict or dilate, is diminished by sympathoplegic and vasodilator drugs, so that the vascular uh, be, behaves like an inflexible tube. As a consequence, the blood pressure becomes extensively sensitive to blood volume. Thus, in severe hypertension, when multiple drugs are used, blood pressure may be well controlled when blood volume is 95 of normal, but much too high when blood volume is 105 of normal. The size of action within the kidney and the pharmacokinetics will be described in the future. So the thiazide diuretics are appropriate for most patients with mild or moderate hypertension and normal renal and cardiac function. More powerful diuretics, for example those acting on the loop of Henle, such as furosemide, are necessary in severe hypertension when multiple drugs with sodium-retaining properties are used. In renal insufficiency, when glomerular filtration rate is less than 30 to 40 milliliters per minute, and in cardiac failure or cirrhosis in which sodium retention is marked. Potassium-sparing diuretics are useful both to avoid excessive potassium depletion and enhance the nutritious effects of other diuretics. Aldosterone receptor antagonists in particular also have a favorable effect on cardiac function in people with heart failure. So the pharmacokinetics is described here, and uh, for example, for the hydrochlorothiazide, most commonly used diuretic for the starting of the treatment. The initial dose is 25 mg per day, and maintenance dose can be up to 50 mg per day. So it has a good long duration of action, 12 hours, so 1 day only dosing, and high bioavailability at 70%. Although tacit diuretics are more natriuretic at higher doses, when used in lower doses, they uh, uh, exert as much antihypertensive effect as the higher doses. That is why uh, there is no any rationale to prescribe higher doses of hydrochlorothiazide, especially for the older people, because they usually uh, comply less with the high doses. So recommended use dose is 25 to 50 milligram. In contrast to thiazides, the blood pressure response to loop diuretics continues to increase at doses many times greater than the usual therapeutic dose. So, in the treatment of the hypertension, the most common adverse effect of diuretics is potassium depletion. So this is common from all of diuretics except the potassium sparing diuretics. Although mild degrees of hypokalemia are tolerated well by many patients, hypokalemia may be hazardous in persons taking digitalis. These are digoxin and digotoxin, those who have chronic arrhythmias and those with acute myocardial infarction or left ventricular dysfunction. Potassium loss is coupled to reabsorption of sodium and restriction of dietary sodium intake, therefore minimizes potassium loss. Diuretics may also cause magnesium depletion, impair glucose tolerance, and increase serum lipid concentrations. Diuretics increase uric acid concentrations and may precipitate gout. The use of low doses minimizes these adverse metabolic effects without impairing the antihypertensive action. Potassium-sparing diuretics may produce hyperkalemia, particularly in patients with renal insufficiency and those taking angiotensin-converting enzymes inhibitors or angiotensin receptor blockers. And spironolactone is associated with gynecomastia. So the second clause is the drug that alters sympathetic nervous system function. In many patients, hypertension is initiated and sustained at least in part by sympathetic neuroactivation. In patients with moderate to severe hypertension, most effective drug regimes include an agent that inhibits function of the sympathetic nervous system. Drugs in this group are classified according to the site at which they impair the sympathetic reflex arc. This neuroanatomic classification explains prominent differences in cardiovascular effects of drugs and allows the clinician to predict interactions of these drugs with one another and with other drugs. The subclass of sympathoplegic drugs exhibits different patterns of potential toxicity. Drugs that lower blood pressure by actions on the central nervous system tend to cause sedation and mental depression and may produce disturbances of sleep, including nightmares. Drugs that act by inhibiting transmissions through the autonomic ganglia or ganglion blockers produce toxicity from inhibition of parasympathetic regulation in addition to profound sympathetic blockade and are no longer used. Drugs that act chiefly by reducing release of norepinephrine from sympathetic nerve endings cause effects that are similar to those of surgical sympathotectomy, including inhibition of ejaculation and hypotension that is increased by upright posture and after exercise. Drugs that block a postsynaptic adrenal receptor produce a more selective spectrum of effects depending on the class of receptor to which they bind. Although not discussed now, it should be noted that renal sympathetic denervation is effective in lowering blood pressure in patients with hypertension resistant to antihypertensive drugs. Uh, Finally, one should note that all of the agents that lower blood pressure by altering sympathetic function can elicit compensatory effects through mechanisms that are not dependent on the adrenergic nerves. Thus, the antihypertensive effect of any of these agents used alone may be limited by retention of sodium by the kidney and expansion of blood volume. For this reason, sympathoplegic antihypertensive drugs are most effective when used concomitantly with a diuretic. The next type is centrally acting sympathogenic drugs, and they were once widely used in the treatment of hypertension, with the exception of clonidine. These drugs are rarely used today. These agents reduce sympathetic outflow from vasomotor centers in the brain stem, uh, and so they act on the brainstem and uh, and allow the centers to retain or even increase their sensitivity to baroreceptor control. The antihypertensive and toxic action of these drugs are generally less dependent on posture than are the effects of drugs that act directly on peripheral sympathetic neurons. The first drug, methyl-dopa, is an analog of levodopa, and it's like levodopa. It's left of isomer of the deoxyphenylalanine and is converted to alpha-methyldopamine and alpha-methylnorepinephrine, and this pathway directly parallels the synthesis of norepinephrine from dopa, and alpha-methylnorepinephrine is stored in adrenergic nerves vesicles where it stoichiometrically replaces norepinephrine and is released by the nerve stimulation to interact with postsynaptic adrenal receptors. However, this replacement of norepinephrine by a false transmitter in peripheral neurons is not responsible for methyl-dopa's antihypertensive effect because the alpha-methylnorepinephrine released is an effective agonist at the alpha adrenal receptors that mediate peripheral sympathetic constriction of arterioles and veins. In fact, methyl-dopa's antihypertensive action appears to be due to stimulation of central alpha-adrenal receptors by alpha-methylnorepinephrine or alpha-methyldopamine. The antihypertensive action of clonidine, a 2-imidazole derivative, was discovered in the course of testing the drug for use as a nasal decongestant. After intravenous injection, clonidine produces a brief rise in the blood pressure followed by more prolonged hypotension. The pressure response is due to direct stimulation of the alpha-adrenal receptors in arterioles. The drug is classified as a partial agonist at alpha receptors because it also inhibits pressor effects of other alpha agonists. Considerable evidence indicates that the hypotensive effect of clonidine is exerted at the alpha-adrenal receptors in medulla of the brain. In animals, the hypotensive effect of clonidine is prevented by central administration of alpha antagonists. Clonidine reduces sympathetic and increases parasympathetic tone, resulting in blood pressure lowering and bradycardia. The reduction in pressure is accompanied by a decrease in circulating catecholamine levels. These observations suggest that clonidine sensitizes brainstem vasomotor centers to inhibition by baroreflexes. Thus, studies of clonidine and methyl-dopa suggest that normal regulation of blood pressure involves central adrenergic neurons that modulate baroreceptor reflexes. Clonidine and alpha-methylnorepinephrine bind more tightly to alpha-2 than to alpha-1 adrenal receptors, And alpha adrenal receptors are located presynaptic adrenergic neurons as well as some postsynaptic sites. It's possible that clonidine and alpha-methylnorepinephrine act in the brain to reduce norepinephrine release onto relevant receptor sites. Alternatively, these drugs may act on postsynaptic alpha-2 adrenal receptors to inhibit activity of appropriate neurons. Finally, clonidine also binds to a non-adrenal receptor site, the imidazoline receptor, which may also mediate antihypertensive effects. Methyl-dopa and clonidine produce slightly different hemodynamic effects. Clonidine lowers heart rate and cardiac output more than does methyl-dopa. This difference suggests that these two drugs do not have identical sites of action. This may primarily on different populations of neurons in the vasomotor centers of the brainstem. Guanabens and guanfacine are centrally active antihypertensive drugs that share the central alpha adrenal receptor stimulating effects of clonidine. They do not appear to offer any advantages over clonidine that are rarely used. I think we can stop here and we will continue at the practice. So thank you for your attention
Okay.
and see you next week.
Okay. See you. Goodbye.
Bye bye.
Thank you.